Hello and greetings from UB. On behalf of the Office of Alumni Engagement, I'd like to welcome you to today's webinar presentation. My name is Joy Rona, and I'm a member of the Alumni Lifelong Engagement Team here at UB. It's National Public Health Week, and it is my honor to welcome today's featured presenter from the School of Public Health and Health Professions, Dr. Nicholas Felicione. He is an assistant professor in the Department of Community Health and Health Behavior. Nick is an addictions and tobacco regulatory scientist, focusing his research on the interaction of tobacco use, behaviors, and tobacco product characteristics and their effect on outcomes such as health and addiction. His research employs various methods, including laboratory studies, clinical trials, naturalistic observation, and secondary analyses of population data sets. Nick started his research and teaching career while completing his MS and PhD in psychology with an emphasis in behavioral neuroscience at West Virginia University. He continued his training with postdoctoral and research scientist positions in the Department of Health Behavior at Roswell Park Comprehensive Cancer Center in Buffalo before joining UB. Historically, the war on drugs has had one mission: fully eliminate drug use. However, not all people who use drugs are interested or prepared to quit, or they may be unsuccessful in their attempts to quit. Since the 1980s and 90s HIV/AIDS activism, the practice of harm reduction aims to reduce risk for those who continue to use drugs. Harm reduction is an approach that meets people where they are to promote health and reduce the risks associated with drug use and other risky behaviors. Harm reduction also expands beyond solely health-related harms and aims to mitigate potential social, economic, and legal harms. In today's webinar, Nick will discuss the principles of harm reduction, share his research in tobacco harm reduction, and how his way of thinking is improving quality of life for people who use drugs. We will leave some time today during the webinar for Q&A. If you have any questions during the presentation, please submit them through the GoToWebinar taskbar question section that's on your screen and chat those to us at any time. In addition, we are recording today's session and we'll all send you a copy within the next 24 hours. It's now my pleasure to turn it over to our featured presenter, Dr. Nick Felicione.
Thank you so much for that wonderful introduction. So hi everyone, I'm Nick Felicione. I'm an assistant professor in community health and health behavior. And like was just explained, my research has really been in tobacco use and focusing specifically on non-combustible tobacco products like smokeless tobacco or e-cigarettes and how these may serve as alternatives that reduce harms for people who are unable to quit smoking. In my PhD at West Virginia, I also did some work on smoking cessation in populations with opioid use disorder, which is kind of what continued to get me interested in harm reduction. So just for a brief outline of my talk, I'm going to give just some general background on harm reduction, what it is, what the goals of harm reduction are, what the main principles of harm reduction are, and why we need it. And then I'm going to go and explain some different examples of harm reduction and work actively going on in harm reduction, some of these including everyday examples that we can all relate to, and then focusing on two specific substances, opioids and tobacco. So just to give some basic background on what is harm reduction. Harm reduction is a set of practical strategies with the goal of reducing the negative consequences of drug use and other risky behaviors. It's often talked about in the context of drug use, and that's generally what I'll refer to throughout this presentation, but it can apply to a wide variety of behaviors. And when I say a set of practical strategies, it really spans a range. We can be talking about an individual's behaviors and certain things one person can do to reduce their risk. And we can scale this up to interventions, programs, and policies at a community level, state, national, or even international level. Harm reduction is also a movement for social justice that believes in and respects the rights of people who use drugs. So harm reduction is often considered value neutral. We don't it's not viewing drugs from a moral or ethical standpoint. It's a behavior that people engage in, and if they choose to engage in that behavior, that's a right that they have. Harm reduction is also varies a lot, and there isn't a single standard definition. Different groups have different approaches. Different people consider different strategies harm reduction or not harm reduction. There isn't a set definition, although there's several principles that outline harm reduction generally. But over kind of the main goal is meeting people where they are, really understanding someone's circumstances, their behaviors, their specific risks, and figuring out how we can mitigate those risks. So generally, the goals of harm reduction are focusing on positive change and keeping people alive. We're trying to reduce harms. We're not trying to tell people that they should absolutely never use substances or they must quit. We're really just trying to make people take positive steps and empower themselves to change and become healthier people. It also doesn't only focus on health outcomes, but it can include social and economic consequences too. So for example, when we talk about decriminalization of substances, that could be a potential form of harm reduction because incarceration and the long-term penalties associated with incarceration bring on a lot of economic and social harms to people. It also involves working with people without judgment, coercion, discrimination, or requiring abstinence. So again, it's value neutral. We're not making any claims about what they should or shouldn't be doing. We're not making assumptions about them based on their behaviors. It's just working with people as they are and where they are. And importantly, it tries to reduce the stigma associated with drug use and other risk behaviors. Risk behaviors can lie on a continuum from total abstinence, which minimizes harm, to really severe use, which can be harmful. But it's not right or wrong. It's just trying to help people get to a place where they can be healthier and hopefully not die from the negative consequences of drug use or other unhealthy behaviors. So some key principles of harm reduction. This came from a really nice paper about integrating harm reduction into a healthcare setting, and I think it summarized the principles nicely. So one being humanism, really recognizing patients, people who use drugs, people who engage in other risky behaviors as individuals with dignity who we value and care about. And along with that, it recognizes harmful behaviors may have adaptive reasoning. People don't wake up and decide, I want to have a substance use disorder today. There's reasons people start using drugs. There's reason people continue to use drugs. And often those reasons can be adaptive and shift to maladaptive over time, but really recognizing that individual as a human first. It's also pragmatic. Drug use isn't going away. People have used drugs for thousands of years and will continue to use drugs. Just telling people to say no or making it a criminal issue doesn't make the problem go away, and we have decades of evidence to suggest that. So we know people are going to continue to use drugs and engage in other risks. So it's really aimed at how we can minimize these harmful effects rather than just ignoring them or condemning the behaviors. And it also, being pragmatic, recognizes some strategies and some behaviors are healthier or riskier than others. It's also based in individualism, recognizing each person is unique and has their own set of circumstances that got them to where they are today. They all have their own reasons for engaging in these behaviors, and each person has their own strengths and needs. So what works for one person doesn't necessarily work for someone else. Risky behaviors are really complex, multifaceted phenomenon that tie into individuals, communities, and social structures. Everyone's behavior is embedded in a larger social context, and we recognize that in harm reduction. Another principle is autonomy. So this is really taking a patient-centered approach rather than a provider-centered approach. The patient knows themselves, or the person who uses drugs knows themselves and their behavior better than anyone else ever can, and they are really the agent of change. A doctor can tell a patient to take a medication or engage in a certain intervention, but ultimately it's on the person to follow that. So this is really about following the patient and understanding their needs and risks and empowering the individual and community as the agents of change. It's also incremental, so it recognizes any positive change and celebrates any movement towards being healthier. So often in addiction medicine and science, abstinence is the ultimate outcome, and if people don't reach abstinence, it's almost considered a treatment failure. In harm reduction, any positive change, reducing use, using in a safer way, are all celebrated and seen as a step in the right direction. But notably, harm reduction doesn't mean no accountability. Instead, it means accountability without termination. So we recognize people are responsible for their own choices. If people are diverting medication, that's still a problem that goes addressed. But just because people don't meet certain goals doesn't mean care is terminated. If someone isn't abstinent from substances, that doesn't mean we should discontinue care or not allow them to have housing. It doesn't require a certain goal or endpoint as a precondition for support. Some additional principles that I think go along with these are just general compassion and acceptance. Accepting someone for who they are, recognizing them as a unique individual and they have unique circumstances, and trying to really understand that and work with them rather than telling them what they should be doing. And rather than abstinence as an outcome, quality of life, both on an individual, community, and societal basis, are really seen as key endpoints. Harm reduction also started as a bottom-up movement. It really went from a lot of advocacy from people who use drugs, trying to advocate for ways that they can be safer and survive risks that are coming up in their environment. We still try to do this by ensuring that individuals and communities have a role in building harm reduction programs and interventions, although as time goes on, this becomes a more mixed bottom-up movement and top-down approach with like governmental policies and things like that. And importantly, harm reduction is evidence-based. So harm reduction strategies should be acceptable to the people who are using them. They should be feasible and possible to implement. They should be cost-effective, and they should have demonstrated effectiveness that they actually work to help reduce harms. Some things that harm reduction explicitly does not do, like I've mentioned a few times, it does not judge and stigmatize people or behavior. It doesn't take an ethical or moral stance on drug use. It doesn't view it as a criminal issue. These are individual and community and societal issues to help people get healthier. It also doesn't minimize the harms associated with risky behavior. So it still recognizes that people who are using, who are injecting fentanyl are at a high risk for overdose. It's not trying to negate that. It's trying to figure out how people can avoid that or be safer. It also doesn't endorse or promote drug use. That's a common criticism, especially when we talk about safe injection facilities. But kind of like I said earlier, people don't wake up and say, well, I want to have a substance use disorder so I can engage in harm reduction. It's just recognizing that people are going to use drugs, and we're trying to find ways that they can do that safely. And it doesn't require abstinence as the only meaningful endpoint. It really focuses on quality of life and the harms they're experiencing. So why do we need harm reduction? There's a few reasons. This is not an exhaustive list, but typical treatments are focused on abstinence, and that's really the only goal of a lot of treatment. But a lot of people are unable or unwilling to stop treatment. So what do we do for that, or to stop use? So what do we do for those people? There's an estimated over 20 million Americans with a substance use disorder. So if these people aren't able to get abstinent, what else can we do for them? And even though there's efforts going on in treatment in harm reduction, people are still dying every day. People are still experiencing long-term harms of use. So really just trying to figure out, before someone reaches abstinence, or if they never will, What types of things can we do to prolong their life and make them safer? And a lot of the reason we need harm reduction is recovering from the war on drugs. I mean, this isn't officially over, but in the 70s, Nixon declared drugs as public enemy #1. A lot of these policies were racialized and had inequitable impact. Like, for example, there were inequities between cocaine and crack sentencing, where 500 grams of cocaine and 5 grams of crack had the same prison sentence. That's not evidence-based, it's a racialized policy. Even one of Nixon's advisors said they were trying to link opposition groups like hippies and minorities with drugs so they could disrupt those communities. And we've seen long-lasting impacts in incarceration, in health, and in how our societies views and stigmatizes drugs as a result of the war on drugs. So we're really just trying to figure out ways to reverse that and help people. And kind of like this protester shows, we don't declare war on inanimate objects like drugs. A war on drugs is really a synonym for a war on people who use drugs. So harm reduction is trying to change that viewpoint and right some of these wrongs to get us to a more healthy and equitable society. Harm reduction strategies cover a really wide spectrum that's not always agreed upon, and there's room for debate on what could be considered harm reduction and also where the limits of harm reduction should be. So for example, in Canada, they have sites that give people prescription heroin. I wouldn't be surprised if people don't support that policy because it is somewhat of an extreme measure. But if we're thinking as harm reductionists, if we're prescribing it, it's quality tested, we know what's in it, we know the exact dose, it's under medical supervision, rather than someone buying heroin on the street where we don't know what's in it, we don't know the purity, we don't know if it's contaminated, and they don't necessarily know the dose. But some things that can be included in harm reduction are ways to use drugs safer, ways to manage use of drugs or reduce the use. Complete abstinence is kind of still a goal, and that's the ultimate form of harm reduction. We recognize that all drugs have harms, and the only way to completely avoid them is abstinence, although that's not feasible for everyone. And you could even argue prevention efforts could be considered harm reduction. So if we get people to never start using drugs on a societal basis, that really reduces harms on a major scale. But we also need to recognize that that doesn't work for everyone. And when we're focused on prevention efforts and telling people not to use drugs, that leaves behind the people who are already using drugs. So it really needs to be a combination of strategies that includes all of these things, from prevention to managed and safer use, to treatments that support abstinence. And in kind of in collaboration, these can all reduce harms on an individual, community, and societal basis. And just a side note, kind of with harm reduction, with this humanistic and person-centered approach, it affects how we use language. So we try to use terms like substance use or drug use, or substance use disorders, rather than substance abuse, misuse, or calling people like alcoholics or junkies. That's stigmatizing language, and we really don't want to do that. Same thing, it's commonly people are referred to as dirty or clean, or having a dirty urine sample. Again, that's stigmatizing language, and it's really not accurate language. Like, they had a positive or negative toxicology screen, their urine isn't dirty or clean. So being aware of how we talk about these things and how we refer to people who use drugs, and really recognizing them as a person first, can go a long way in both reducing stigma and increasing support for harm reduction strategies. So now I'll move into some examples of harm reduction. And some of these are things that are policies that are not widely debated, that are used in everyday life, and I don't think many people have an issue with them. So for one, seatbelts. Cars didn't always have seatbelts. They were introduced and they reduced the risks of driving. We don't tell people not to drive, just don't transport yourself anywhere and just stay put. We find safer ways for them. And these evolve over time. Like we think of car seats, that can be another form of harm reduction. We don't tell people don't bring babies in cars. That's not feasible and that's not pragmatic, but we find ways to do it safer, and that changes over time as we build more evidence and understand more about it. Even things like reflective vests and general like personal protection equipment. These are harm reduction. We don't tell people don't work on a construction site or don't run at night. We find safer ways that they can do it. Bicycle helmets are a similar one. We even see this with COVID, right? Like lockdowns went on for a while. They kind of tried to push a message of don't go anywhere, but we just know that doesn't work. People are going to engage socially and need to engage socially. So we adopted guidelines regarding face masks, vaccinations, and social distancing. Are those perfect strategies that completely prevent COVID spread? Absolutely not. But are they ways to engage in social behaviors more safely and reduce the risks of the spread of COVID? Certainly. So those could be in a way considered harm reduction strategies. And we often see this with sex education and how we approach sexual behavior. We teach sex education at a relatively younger age, but generally we don't teach abstinence only. We teach people how to have safer sex. We teach people about condoms and preventing STIs. Is giving condoms to a teenager or college student encouraging them to go have sex? Not necessarily, but it's providing them with the tools to do so safely if they engage in that behavior, because it's not realistic to just expect they won't or turn a blind eye. So if we don't provide them with these resources that can reduce harms, that can lead to things like more unwanted pregnancy, more STI spread. So really in daily life and normal behavior, we found a lot of ways that people can reduce risks. Another one that's brought up sometimes is sunscreen. We don't tell people avoid the sun completely. We provide them with potential treatments and strategies on how to reduce the risks so they don't get skin cancer or at a reduced risk of developing skin cancer. So even though harm reduction for drugs and other risky behaviors can be really controversial and hotly debated, these are things most of us are doing in our daily lives and not even really thinking about. And these things, for the most part, are not super controversial. So moving into opioid use, this is just to set the stage a little bit. On the y-axis here, we have deaths per 100,000, and on the x-axis, we have graphs. And there's a couple of lines here, the black being overdose from any opioids, purple from synthetic opioids like fentanyl, blue being heroin, and kind of the teal being commonly prescribed opioids. And the opioid crisis is seen in 3 waves. So in the late 90s, often due to how opioids were prescribed and pill mills and things like that, we really saw an increase in overdose deaths from prescription opioids. And we saw that start to rise over time and then level out somewhere around the later 2000s. But in 2010, we saw another wave with an increase of heroin overdose that we see here. A lot of this could be people from switching from those prescription opioids towards heroin. And then a couple of years later, we see this huge increase in synthetic opioid overdoses, particularly related to fentanyl. When you talk to people in working in harm reduction in the community, like at Evergreen Health or Erie County Department of Health, they basically say there's very little heroin in the community now. It's almost all fentanyl. So this is just kind of showing, despite the active treatment efforts we have, and even despite some of the harm reduction efforts we have, people are still dying from the use of these substances, and abstinence may not be achievable for everyone. So we are just trying to find ways that we can reduce the risks, reduce overdose deaths, reduce sharing needles that can lead to the spread of STIs and other diseases. Opioid harm reduction is interesting in particular because it has a really wide span. Some of it can be individual behaviors like safer injecting practices, teaching people about wound care so they don't get abscesses and infections. It also includes syringe exchange and access programs, so trying to distribute clean gear to people so they can use drugs without sharing needles, without reusing needles and putting themselves at risk for harms. It can also include treatments that like medications for opioid use disorder, and I'll talk a little bit more about that. Overdose prevention, there's a wide variety of strategies that are employed. I'll talk about those more. And even up to safe injection facilities or supervised consumption sites where people can use drugs like heroin or fentanyl or stimulants in a safe and monitored environment. And I'll just note, the US has some of these things, but really Canada and some European nations are at the forefront of harm reduction and have been leading this and engaging in these practices for a long time as part of their national healthcare system. So a note on supervised consumption sites. On the picture on the right, I have a picture of Insight, which is part of the Canadian system. It's a supervised consumption site in Vancouver. And you can note it looks almost like a doctor's office or a clinic. It's a sterile environment. It's not exciting or attractive necessarily. It's a place for people to go and to use their drugs in a safer fashion. These are illegal in the United States, although one legally sanctioned supervised consumption site has opened in New York City with the city's approval, known as On Point. So that's a step in the right direction, but again, it gets difficult when it's federally illegal, but then some local communities are willing to make these places legal and give them a chance. But overall, these have a positive impact on health of people who use drugs. So they reduce overdose deaths. These places carry Narcan, which can reduce overdose deaths. They have doctors and medical staff on site. It also reduces the risks of disease transmission. So people are provided with alcohol pads to prep. They're taught how to inject safely. They're provided with clean needles and other resources to reduce their risks. And it also shows to have an impact on the community. So there's data to support that it reduces injecting in public and disposing of needles in public. So there was one study from On Point where people basically reported if they did not have On Point as a place to use drugs, they'd likely be using in a public location like on the street. And it also reduces unsafe injecting behaviors. So these are where we can teach people how to properly inject, how to find a vein, how to rotate veins, and how to clean their wounds after they use to try to promote overall health and reduce the negative risks. And another benefit of these types of sites that I didn't mention here is they often help connect people with other resources, and in general, just a community of peers who are going through a similar experience, and some have lived experience and some are relatively new users, and they can share information and strategies and really encourage each other's self-efficacy individually and as a community. There are also syringe service programs. These are more common, but federally still a little bit complicated. They can come in a couple different forms, one being syringe exchange, where like we give you 5 syringes and you need to give us 5 back. Or they can be syringe access, where you're just providing people with syringes, and then usually return sites are distributed throughout the community, which is another way of kind of meeting people where they are and giving them resources in their own environment. Like I mentioned with supervised injection sites, these are often integrated with other resources. So education resources on ways to be safer, health resources and social resources to try to connect people with resources like housing or mental health care or finding a job and things like that. There's a lot of evidence to support positive outcomes from syringe service programs, like reducing disease transmission. Because again, if you have access to syringes, now you don't need to share between people and you don't need to worry about as much transmission of things like HIV, HCV, and Hep C. Some of them show potential for reducing overdose rates. Something I found interesting is some actually show evidence that it reduces injection drug use. And in relation to connecting people with other resources, there's evidence to show people who access syringe service programs have an increased likelihood of entering treatment. Common criticisms that there is no scientific evidence for is that these types of programs increase improper disposal of syringes. So a lot of people oppose syringe exchange programs because they think, well, people are going to go get their syringes and then they're going to litter it on my lawn. It's not to say that that is impossible and never happens, but there at least is not a good scientific evidence base to suggest that this is the case. And actually the opposite is the case, that people are more likely to dispose of their needles in a proper way. There's no evidence that it increases crime, although that's a common reason cited for why people don't want these in their neighborhoods. And there's no evidence that this increases drug use. So that's another common criticism. This is making it attractive. Now everyone's just going to want to use drugs. I don't know anyone, and I've never seen any literature to suggest that people knowing that clean syringes are available makes them more likely to use drugs. And this is just a quick map from the North America Syringe Exchange Network. This is just basically what it says. It's a collective that collects data or takes data on where syringe exchange programs are throughout the United States and what type of resources they provide. We see a lot of concentration where we see high rates of overdose in like Appalachian countries. We see less in Middle America, and then we see a lot in cities along like the West Coast and Northeast. And these really started in the 1980s with a lot of small-scale pilot programs or people just doing individual work. But over time, these have proliferated and really become a public health strategy for reducing the risks of opioid use. And just to show the level of impact, so according to some studies, these types of program reduce disease. So cities with needle exchanges have reduced rates of HIV among people who use drugs compared to cities that don't. It's also cost effective. So spending money on harm reduction and treating addiction saves money compared to incarceration and other forms of healthcare. And in the top right, it suggests that places that have needle exchange programs actually reduce syringe litter compared to places that don't. And even without looking at comparison, it just shows their local their impact and how many people they're reaching. Like over 2 million syringes provided, almost 7,000 doses of naloxone and 14,000 fentanyl test strips. So even though these are aimed at syringe exchange, they're providing other resources that are helping people use safer and reduce the risk of overdose. There's also several overdose prevention strategies. A primary one being naloxone or Narcan, which is a nasal spray that basically blocks the effects of opioids in our brain. So if someone is overdosing on opioids, using the Narcan nasal spray can knock those opioids off of the receptors and reverse that overdose. And this is becoming more widely available. The FDA just approved the first over-the-counter naloxone, although there are some questions about price and will this truly increase access to the people who need it most. But Narcan is available in a lot of city sites. I know in Erie County, they have text messaging services that you can text a number and receive Narcan. And notably, this shouldn't only be held by people who use drugs. Anyone can reverse an overdose. Anyone who has opioids in their house, like opioid divergence or accidentally taking too much, can happen. So this is really something that training is fairly easy and fairly quick, and anyone can do it. And it's a wise thing for anyone to have in their house or on themselves, just in case. You'll never know if you might need it. Fentanyl test strips are another one. So I mentioned fentanyl, which is a very potent synthetic opioid, is commonly in the drug supply now, including cocaine in Western New York. So using test strips to test for fentanyl, if someone's using cocaine, they likely don't have opioid tolerance and are not prepared to take a powerful opioid. So distributing test strips so people know what's in their drugs, it doesn't necessarily prevent them from using them, but then we can also teach them safer ways, like having Narcan, doing test shots and things like that. That's the next bullet point. There are individual behaviors, like encouraging people to take test shots. If you're not sure of the potency, don't shoot your dose all at once. Try a little bit, see how you feel, and then go from there. Use with someone else and alternate. Let one person use, see what happens, have the other person prepared with Narcan, and take turns. There are also never use alone hotlines. So people who use alone are at high risk for overdose deaths, because if they overdose, there's no one there to help them. So that's why these hotlines exist. Again, it's not about judgment. It's not trying to convince people not to use their drugs. It's someone on the line talking to them through their drug use and basically saying, like, hey, after you use, if I don't hear from you for 2 minutes, do I have permission to call an ambulance? So this is just another way that we can reduce deaths from overdose. And relatedly, Good Samaritan laws. So this is when if you're with someone who overdoses, you can call and you won't necessarily be prosecuted for having drugs or drug paraphernalia. And these are all ways to both reduce stigma and reduce the likelihood of overdose deaths. And we can see it's a wide variety of strategies. Some are public health strategies, some are pharmacological, some are more policies and laws, some are individual behaviors. So there's really a wide variety of strategies we can employ to reduce harms. We also have medications for opioid use disorder. There's a wide variety of medications that all work in different ways. I'm not going to go into the details of all of them, but you've likely heard of methadone or buprenorphine combined with naloxone, like Suboxone. These all have kind of varying mechanisms of action and have trade-offs. But if we can get people to switch and use an approved treatment that we know is safe, that might be considered a form of harm reduction, although people can debate the difference between treatment and harm reduction. But an important way is also how we structure these treatments and clinics that support them. And an important aspect of harm reduction is making these low threshold. So making them easy to access and not necessarily require abstinence. So one paper gives a guideline for what would be considered like low threshold medication assisted treatment or medications for opioid use disorder. So one being same day treatment initiation. If someone comes in and wants to start treatment, if we tell them you need to wait 2 weeks to get a prescription, what's going to happen in those 2 weeks? How many people overdose and potentially die in those 2 weeks between wanting to start treatment and when they actually can? We need strategies and we need policies that if someone comes to us today and says, I want help and I want to start treatment, we can start them that day. The second point is focusing on harm reduction, not abstinence only. So a lot of clinics or to receive certain medications, you need to demonstrate that you have a negative tox screen for opioids and even other substances. That's not necessarily harm reduction if we're requiring people to be abstinent, and it's not necessarily realistic to require people to be abstinent. The point is, if they're starting treatment and starting to change their behaviors, that's a positive change we should acknowledge. That may be a step for them on the way to abstinence. And kind of related to a lot of these clinics and certain rules of different programs require abstinence from all substances. So if you go in seeking treatment for an opioid use disorder, they might expect abstinence from cocaine or methamphetamine or cannabis, but we're giving them a pharmacological intervention that's meant to treat opioid use disorder. So why would we necessarily expect it to have a clinical impact on other substances that have different mechanisms? A third way to have it low threshold is to be flexible. And this can be in terms of prescription and dosing or treatment. So some of these programs also require people to go to like group therapy, like an NA type group. And while that may work for someone or for some people, it may not work for everyone, and it may not be feasible for everyone. Some people have a lot going on in their lives, and they're trying to manage families and jobs and getting food on the table and unstable housing. So requiring additional factors towards treatment often can make fewer people seek out treatment or people drop out. We really want as many people to receive this as we can. And then finally, making these available in non-traditional settings or where people are. So emergency rooms, primary care physicians, like mobile vans, getting into rural communities, really trying to find where people are experiencing harms, where people want help, and reaching them there. Notably, like I talked about, accountability without termination. Low threshold doesn't mean no threshold. So we're not giving anyone these medications. It's still for people who meet opioid use disorder diagnostic criteria and have had medical and psychiatric assessments. If people are diverging medication, those issues are still addressed, but it also doesn't require the high threshold of abstinence or they'll be kicked out of treatment. But notably, higher threshold programs may work for some. So I don't think we should say no clinic should have high threshold barriers, but we should recognize different strategies work for different people and employ as many strategies as we can so we're reaching as many people as we can. To shift to tobacco for a couple of minutes, the 2014 Surgeon General report on the health consequences of smoking directly states that the burden of death and disease from tobacco use in the United States is overwhelmingly caused by cigarettes and other combusted tobacco. Rapid elimination of their use would dramatically reduce this burden. So without coming out and saying it directly, you can interpret this as somewhat of an endorsement of harm reduction. It doesn't necessarily say everyone needs to quit nicotine altogether. It really focuses on cigarettes and getting people away from cigarettes. Notably, cigarette smoking is the leading preventable cause of death and disease in the US. About 1 in 5 deaths, I think, are attributed to smoking, and it causes over 480,000 deaths annually in the US. Despite that, people don't have success quitting. So about 70% of people who smoke wish to quit, and over half make a quit attempt in a year, but less than 10% are successfully smoke-free. So like that graph on the right has it broken down by age. Even when you're looking at some groups, over 80% of people have tried to quit in the past year. But when we're talking about one day out already, 50% of people are almost not successful. And when we're talking about 6 months out, we have less than 10% of people who are maintaining long-term abstinence from smoking. So this leads to the question of what can we do for that 90% of people who don't quit? An interesting example comes from Sweden and a product called snus. Snus is a smokeless tobacco product that's cured in a different way that reduces some of the carcinogens in tobacco, and it typically just comes in like a little pouch that people put in their upper lip. And in Sweden, they saw a really big uptake in snus and people switching from smoking to snus. And overall, there were a lot of public health benefits seen from the use of snus rather than cigarettes. So in Sweden, there's demonstrated lower risk for certain cancers, cardiovascular disease, and pulmonary disease of people who use snus. And the increased uptake in snus was associated with reductions in smoking prevalence, reductions in lung cancer, and reductions in myocardial infarction. And notably, we don't see like a gateway effect. We don't see a lot of more non-users taking up snus than we see for like cigarettes. And we don't see people transitioning from snus to smoking. And this graph on the right just shows incidence rates of different diseases, with the blue bars being people who smoke, the middle bars being people who use snus, and the right bars being people who never use tobacco. And really, for lung cancer, oral cancer, and pancreatic cancer, we see majorly reduced risk compared to people who currently smoke, and often similar levels of risk between non-tobacco users. So overall, this became known as like the Swedish experience. And there's kind of talk about how this can be translated to other countries. In the United States, we have several non-combustible tobacco products. So a lot of the harms from cigarettes comes from the act of combustion. You are burning this, which exposes you to carbon monoxide, tar, and a lot of carcinogens and chemicals. Non-combustible products don't burn, and because of that, may have much less risk. So this can include products like e-cigarettes seen over here, which there's a wide variety of them. We have smokeless tobacco products, which also come in different forms. More recently, we see nicotine pouches. So these have nicotine, but not tobacco in them. And heated tobacco products. So these do have actual tobacco, but they're meant to heat rather than burn the tobacco, and reduces the risk. And tobacco products fall on a continuum of risk. This is from a study. I don't give a ton of weight to the exact level of harm that they estimate, because everything is estimated and it's hard to come up with an exact precise number. But notably, cigarettes on the right are the most harmful form of tobacco. And then below that, really any combusted form of tobacco products are still pretty harmful, although some are still much less risk than cigarettes. Then moving to the left, we have smokeless tobacco products. We know there's risks associated with smokeless tobacco products, particularly for like mouth, gum, esophageal cancer, and things like that. But compared to cigarettes, which cause also lung cancer and more cardiovascular issues, we see less of that with smokeless tobacco. So presumably they may be a way to reduce the harms of cigarettes. And then as we move further left, we get into other more modern non-combustibles like e-cigarettes, these oral products, and then what we consider our treatments like nicotine replacement therapies like the patch and gum. We do have a legal pathway in the US to be recognized as a harm reduction product. So through the FDA Center for Tobacco Products, companies can apply for a modified risk tobacco product, which are products that are sold or distributed for use to reduce the harm or the risk of tobacco-related disease associated with commercially marketed tobacco products. Companies need to provide a lot of data that's evaluated for the relative health risks, the increased or decreased likelihood of people quitting tobacco altogether rather than switching, the increased or decreased likelihood of uptake among non-tobacco users, the risks and benefits of compared to smoking cessation. But the FDA has authorized several modified risk products. One of these here being general snus, so that's snus like we see in Sweden, although these products just haven't taken off in the US. They've approved very low nicotine cigarettes, so these are cigarettes that are meant to have nicotine levels that are so low that they're considered that they don't produce dependence, and thus people are less likely to smoke them. IQOS is one of those heated tobacco products, and even recently in the last couple of weeks, they authorized a classic smokeless tobacco product, Copenhagen Classic Snuff, as a modified risk product. So these companies can make claims that completely switching to their product reduces the risk of disease compared to cigarette smoking. So even tobacco harm reduction is still really controversial and hotly debated, especially in regards to e-cigarettes. Generally, as a product class, they are less harmful than cigarettes, although there are a lot of concerns about youth and adolescent uptake and unknown long-term risks. So we still don't know the exact path to take, but there is more interest and movement towards tobacco harm reduction. And Brian King, the director of the Center of Tobacco Products, gave the Saxon Graham lectureship last week, I think it was, and he acknowledged that harm reduction has a role in the FDA strategy, and that there are products like e-cigarettes that may be less harmful than cigarettes for an individual, but the FDA's job is really to assess whether these products are appropriate for the protection of public health. And then just some final notes. So I gave examples from opioids and tobacco specifically, but harm reduction can span out much further than that. It can apply to really any substances we talk about. Cannabis harm reduction is gaining more traction as more states are decriminalizing and legalizing and setting up regulatory frameworks. Like these regulations that we put on cannabis, on product taxing and product labeling and knowing quantities, like these are all potentially forms of harm reduction compared to people getting cannabis on the street where they have no idea where it was grown, how it was grown, what the THC content is, what else is in it. Sexual behavior and sex work is another area where harm reduction is really common, reducing the spread of STIs, reducing the spread of HIV, reducing violence and other harms against sex workers. It's also being brought into other behavioral conditions like gambling, eating disorders, and self-harm. And even technology use and like social media addiction, I've seen people talk about harm reduction for. And then kind of like I mentioned for COVID, infectious disease is an area where we can focus on harm reduction. So overall, even though there are specific strategies, I think everyone can kind of focus on those principles of harm reduction and think about how to integrate those into daily life, practice, and healthcare. And then just a final note, here is a non-exhaustive list of resources. In Buffalo and Jamestown, we have Evergreen Health, which is a really great community organization that provides harm reduction services. That covers a lot of what I talked about. Erie County Department of Health and the Opioid Task Force or the Opiate Epidemic Task Force is doing a lot of work in this area. New York State have the Office of Addiction Services and Supports, and all of these have a good online presence with a lot of information, but then a lot of work that they do. This scales up on a national level. SAMHSA has a lot of information and interest in harm reduction. National Institute of Drug Abuse and National Institute of Health funds research on harm reduction, like the Helping to End Addiction Long-Term or HEAL initiative. Establishes a research network to test harm reduction strategies in communities. And then we also have some advocacy groups like the National Harm Reduction Coalition, Harm Reduction International, and Drug Policy Alliance, which are really pushing our lawmakers, our communities, and individuals who use drugs make a push towards harm reduction. So that kind of wraps up my talk, and I'm happy to take any questions with a couple of minutes we have left.
Thank you so much, Nick. Just seeing how many organizations that are up on the screen right now that are sort of pushing forward this great work is really impressive. I myself personally knew very little about harm reduction until today's presentation. So I'm very glad to hear that there are so many professionals out there that are pushing for this. We do have one question so far that came in, and the comment reads, kind of coming off of my comment, is this all sounds so great to support the individual. What are some of the arguments against harm reduction that you are currently pushing against, to trying to promote your work against? What are some of the arguments that people are bringing against your work?
Yeah, so that's a great question. And some of them I mentioned throughout the talk. So a big one is that harm reduction is condoning, supporting, or promoting drug use. And really, that's just not accurate. It's not ignoring or condemning drug use. And a lot of people think, well, if you're not condemning it, then you are promoting it. But I don't see it in that way. People who believe in harm reduction are not encouraging people to use drugs. And really, if you talk to anyone in the harm reduction stance, their opinion is, we would love it if no one used drugs, and we would love it if all of the people we work with are able to be abstinent. But that's just not real life. People are going to use drugs, so we need to find safer ways to use them. So that's a big one. And a lot of people are concerned about, a lot of people have stigmatized views of drug use and are concerned about things of crime. Like when we talk about syringe exchange programs, you get a lot of the not in my backyard, like, sure, this is a great idea, but if you do it around my house, that's going to bring these people here into my neighborhood and hanging around my house and reduce my property value. But like we showed, we have data to suggest like that's just not the case. It doesn't increase crime. If anything, it actually makes people safer and makes people less likely to use drugs in public, and other factors. So those are common, and it's difficult, right? Like providing people with data isn't always enough to change their mind. So really just finding ways to connect with people and try to reduce stigma and bring out that human side of these risky behaviors are the things we try to do to fight against that. But it's difficult for sure.
Well, thank you for all your work that you're doing to fight that stigma and see the individual. It is truly important work. Here's the next question I have from somebody on the line. Are there any harm reduction products like snus for cannabis that would be acceptable for teenagers?
So I don't think in general, right, it gets difficult when we talk about certain populations like teenagers, because especially they have young developing brains. We know people who start using substances at earlier ages experience more harms and have poorer longer term outcomes. But this is where it gets difficult, because if we focus on prevention only, we leave behind those people who already are using or are likely to use. So it's certainly a balance. With cannabis, we don't quite know yet. There are certain things like using like a dry herb vaporizer rather than smoking cannabis is likely to be less harmful, because again, we're not combusting, you're not getting exposed to carbon monoxide and a lot of these byproducts of combustion and carcinogens. You're just heating the cannabis to effectively get THC out of it. So that may be seen as a form of harm reduction, but everything has its trade-offs. Like edibles may also be harm reduction compared to smoking cannabis, but edibles may have their harms in that they have a long onset. People are likely to redose. They're often packaged as things that look like candies. And kind of compounding all this, cannabis is still federally illegal, so it makes it hard to research, especially in a lab setting. So we don't have all the data, but there's certainly people interested in working in that area. But the question specifically mentioned teens, and that becomes a really difficult area. And we need to try the best we can get people to delay use or maybe manage their use. So go from, rather than using daily, can you use weekend nights or something like that? But finding a strategy that's realistic and we'll help them reduce harms. It's complicated, but there's some things in place.
It does sound very complicated. Well, Nick, that brings us to the top of the hour. On behalf of the Office of Alumni Engagement, I would like to thank Nick for sharing his time, knowledge, and expertise with us. As a reminder, this webinar has been recorded, and you will receive the recording link within the next 24 hours. Next week, we have 2 webinars for you. On Tuesday, join us for a special webinar about the 2024 eclipse to learn the best viewing opportunities, and hey, UB is one of those sites. And then on Wednesday, learn more about how teachers can use their classroom talents to be their own business owners. More information on all of these upcoming webinars, as well as the webinar archive library, can be found on our webinar webpage. And that link will also be included in tomorrow's follow-up email. Thank you again, Nick. Thank you all for attending today. Take care, stay well, and enjoy the rest of your day.
Thank you.